and welcome to Peak Health with Dr. Gupta. This show is for those who want to optimize their health, maximize their genetic potential, and have some fun along the way. If you like our show and want to learn more, please visit our website at peakwellnesshealth.com, which is linked in the show notes below. Here you can gain access to a 10-day body reset module, which teaches you about diet, sleep, meditation, exercise, and guides you on how to drop your blood glucose, blood pressure, body fat, and improve your biomarkers all in 10 days. Also, a body optimization module, which teaches you how to lose fat and build muscle. Finally, there's a link to get one-on-one consulting with me. In today's episode, we're going to discuss something we all do, or should at least do for a third of our lives: sleep. This is the second in our series on this topic. The first covers sleep hygiene and some natural tips and tricks that you can do to achieve better sleep. This episode is an advanced one where we discuss what happens if those modifications and suggestions don't work. We'll learn about sleep apnea and a bunch of other fun things. To guide us through this, today we have Dr. Ali Maghsoudi. Ali is a good friend of mine and specializes in sleep medicine, as well as general, nuclear, and preventative cardiology. He's board certified in sleep medicine and cardiovascular disease, and he currently works for Virginia Heart. Ali and I have known each other for a number of years and also are a part of a mastermind group where we discuss medicine, current events, and just have fun. If you haven't heard of a mastermind before, please look it up. It's a great way to use everyone's collective intelligence for a higher purpose. So welcome, Ali.
Thank you, Ravi. That's a great, that was a very wonderful introduction. Great to be here. But I want to just say we've known each other a little bit more than a few years. I think we've known each other since early 1990s. So
yes,
which means we're getting a little old.
yes, many years I've known Ali. I remember you back in the day. We had a lot of fun back then, and it's been great growing up and knowing you as we've developed our careers. Today, I'm happy to have you discussing sleep. So we'll start off with some simple questions. What is a sleep study? And this is what people will likely need if the standard behavioral type therapies don't work. They need a sleep study. So what is that, and why would somebody need a sleep study?
Sure. So a sleep study, basically, there are two types of studies. There is home sleep study, and there's actually a sleep study that you go and spend the night in the lab. And in the lab, they record you, they do video recording, they put a variety of electrodes on your head and scalp. They look at your brain activity. They also assess your respiratory pattern, your oxygen saturation, which is the level of oxygen in your body. They look at your limbs, your limb movements, and they look at your respiratory pattern and your muscle movement of your thoracic and abdominal cavity. And based on that, there are criteria they look at. Usually the purpose of a sleep study is to assess whether you have obstructive sleep apnea. And there are a variety of criteria that they use to diagnose you with sleep apnea. There are other indications for a sleep study if you're worried about restless leg syndrome, if you're worried about parasomnias. Those are the patients who act during their sleep. If you're worried about some type of seizure disorders that happen during sleep. But there are different protocols that you can use. But that's really the main purpose in general of a sleep study, to diagnose you with obstructive sleep apnea or central apnea. The home sleep study has advanced dramatically in the past several years. The technology has advanced, and it's actually very convenient for the patients. It's not as extensive and doesn't give you as much as information as an in-house sleep study, but basically it's a device that you put it on yourself, and the device detects how much sleep apnea you have and whether you have any episodes of apnea or hypopnea during sleep.
Excellent. So the first step, if you decide or determine that you need to get a sleep study, which some of the signs and symptoms obviously would be just having difficulty falling asleep, not having restful sleep, snoring, or having apneic periods while you're sleeping, then you would see someone like you to get set up for the study. Is that correct?
Or a primary care physicians as well. As historically, as a medical profession, we have undervalued sleep. So this was not something that the doctors would really look into it. And I'm not really sure about the reason why, but one was that we didn't really know the value of the sleep. Number two was that residency programs, you were not supposed to get sleep. You were just supposed to function nonstop without sleep. And if you basically told your residency supervisor that, oh, I made a mistake and I was sleepy, they would just laugh at you. So historically, the physicians grew up in this culture that, we need to be functioning on our maximum level, on our top performance, even if we're sleepy. So we kind of grew up in this environment that we didn't really care much about sleep. And about 10 years ago, multiple studies came out that said, the value of the sleep, the sleep is important to diagnose obstructive sleep apnea. It's important to get enough sleep. A field of sleep medicine was born. Now you actually have to do a fellowship in sleep medicine, so it's more structured. It's board certification. So this is really how the system evolved. But if you're worried about sleep apnea and you think that you might have some element of obstructive sleep apnea or other sleep disorders, usually your primary care physician should be able to start that process. And you can also see a sleep physician as well.
Yeah, it's funny that you mentioned that about our training, because I clearly remember not getting sleep and staying up throughout the night was like a badge of honor, right? You're just like, oh, yes, I don't need sleep. I can actually function and take care of patients and do what I need to do without any sleep. And that's how we were all trained. And we almost project that on our patients, like, hey, look, you don't need to sleep. But just as you mentioned, the more we're studying this, the more we realize it's so important to get a good restful night's sleep. And it sets you up for success in so many ways. Not only does it help prevent some of the diseases we're going to talk about in a little bit, but then you just in general feel better, you function better, your mind is clear. And you also tend to eat a lot more when you're sleepy. You eat a lot more carbohydrates, you gain a lot more weight when you don't get enough rest. So, so many benefits. So going back to the sleep study, now you mentioned obstructive sleep apnea. What is obstructive sleep apnea exactly?
Yeah, so obstructive sleep apnea basically is, in layman term, is that when you sleep, you basically stop breathing or you have shallow breathing and your oxygen level goes down. That's pretty much the basic term for sleep apnea. So, for example, like in Middle East, and this is very common. This is underdiagnosed. You look at every study, they say basically look for sleep apnea. The problem is that about 50% of the patients, they can have clinically significant sleep apnea, but they don't have much symptoms. And it's important to look into these things. For example, previously, 10 years ago, maybe I would see a patient on 3 medications for the blood pressures. I would do this workup and always check for zebras. Now the first thing that I do is check for sleep apnea. So we've become more educated about sleep apnea. We've become more, we know what to look for. But that's one of the main things that we see. There is a huge population of patients in sleep apnea, especially in cardiology clinic, who have undiagnosed sleep apnea. And it's really, it's really the primary care physicians or cardiologists who diagnose these patients.
So you're saying sleep apnea could lead to other complications like high blood pressure?
Yes, absolutely. So high blood pressures, arrhythmias, it can worsen congestive heart failure. It can cause lack of concentration. It can actually exacerbate attention deficit disorder. It can exacerbate your depression or anxiety. It can cause erectile dysfunction. So these all can be a manifestation of untreated obstructive sleep apnea.
And the classic is when our partners are sleeping next to us, pushing us like, "Hey, wake up! You're making too much noise. You're snoring way too loud." That's like the classic thing you hear. How does one diagnose this? Consider this diagnosis?
Yeah, good question. So it's interesting because in some cultures, like snoring is good. It's like, oh, he's snoring. He's really enjoying his sleep. I think actually like I read somewhere, I might be mistaken, but they say like the first description of the sleep apnea was in one of the Charles Dickens book. The Pickwickian syndrome is being described in Charles Dickens. So in some cultures, actually, like snoring is considered healthy. He's really enjoying his sleep. He's snoring, but a lot of times, actually, the significant others report this. They say this gentleman snores, stops breathing. I get worried. I have to shake him up. So a lot of our patients who come in, actually, the significant other starts the whole process. She's the one who complains of snoring. In lots of patients that we see in cardiology clinic, like first onset of arrhythmia, such as atrial fibrillation, we immediately think of obstructive sleep apnea. And also clearly has shown that in people with heart failure, if you treat the sleep apnea, the incidence of heart failure decreases. So we have a variety of conditions in the cardiology clinic when the untreated sleep apnea, it actually exacerbates the problem.
Interesting. And what causes sleep apnea? We all know, obesity is related to sleep apnea. And we were discussing this prior to this episode where, classically people with an enlarged neck circumference get this diagnosis because that puts pressure on your trachea. And your trachea is, in fact, while you're sleeping, it's quite narrow. People don't realize how narrow your trachea gets when you do sleep. And then when you are, when you have that excess weight, it can compress that. But what are the other types of things that can cause it?
Yeah. So classically, neck circumference can basically increases your risk of obstructive sleep apnea. So what happens is that you have the trachea, which is this small tube. And when you're sleeping, all of this tissue in the back of your throat kind of falls and partially obstructs your airway. So imagine like if you're sleeping and I come to your bed and every 1 minute I just choke you and I choke you and then I let it go and I choke you and let it go. And this is pretty much what's happening in these patients. There's also the anatomy and the jaw structure. So there's a huge incidence. I mean, there's a high incidence of obstructive sleep apnea in Middle Eastern population. And those patients are not necessarily obese. It's just the jaw structures. If you have a protruded jaw, it increases your risk of obstructive sleep apnea. Same thing with Asians. When we see Asian population or clinic, a lot of them, they have a low body mass index, but because of their jaw structures, they have sleep apnea. So there is a little bit of an art component involved. You can't just really go by the whole neck circumference. There are people, there are patients because of their jaw structures, they have sleep apnea.
Okay. So there's some anatomical reasons. What about as you age? Is that a risk factor?
So it is. So let's say like I have a sleep study. Okay. I have a sleep study and, I stop breathing like 5 times per hour. And I maintain the same body weight, and we repeat this sleep study 10 years or 20 years down the road, either male or females. What happens is that the degree of sleep apnea worsens. And the reason for that is that when we age, we lose muscle tone. Testosterone level goes down, estrogen goes down, muscle tone decreases. And a lot of these collapsed airway depends on the muscle tissue and how rigid it is. So usually with age, the degree of sleep apnea increases. Also, other things can exacerbate sleep apnea. Like, let's say you have mild sleep apnea and I suddenly make you drink 4 alcoholic beverages. Pretty much your sleep apnea on that day is going to be worsened. So it is a little bit of a dynamic process as well. It depends on how much alcohol, for example, you have. There is a positional component involved as well in a lot of patients. So if you're sleeping on your back, most likely your sleep apnea will worsen, but if you sleep on your right or left or on your stomach, probably the degree of sleep apnea improves. And it also depends on the weight too. For example, if you have a borderline sleep apnea and you gain 20 pounds, your borderline sleep apnea probably is now clinically significant.
It's funny you mentioned we discussed the age part, because I was on a trip relatively recently with a couple of friends who you know quite well. And I was on a trip with them 12 years ago, and we shared a room back then, and we decided, hey, let's try this again. 12 years later, we're on this trip. We share a room, and none of us could sleep because whoever fell asleep first would start snoring and keep the other ones awake. and we didn't differ, except for maybe one of them. We didn't have too much more body weight, but it was like we were that much older.
You guys didn't party too much those nights, huh?
Yeah, and the alcohol may have played a role.
That's a possibility. Yeah.
Yes. Now that you mentioned that, so and I could see people being frightened or scared of like, hey, look, I've got this. I potentially may have this condition. I'm snoring a lot. I don't want to, I'm scared of what will happen, because all people think about are those the BiPAP or CPAP masks.
Yeah.
And they see those and they're like, I don't want that. I'm not even going to go in for the sleep study. But what you're saying is, hey, look, it could be positional. There could be other modalities of treatment.
Yeah. So, everybody, when they see CPAP or BiPAP, they get a little bit hesitant. They think it's not romantic. Sometimes people get claustrophobic. And actually, if you look at our clinic or any clinic, out of 100 patients, 50% love their CPAP. They can't really live without them. Those are the patients who have a lot of fatigue and tiredness, and those are the ones who actually are going to be very compliant, because you immediately see after like the first CPAP titration or the first sleep study, they say, "Oh my God, that was wonderful, that was amazing." That patient is going to be very compliant because it feels so good. But then 25% of our patients, they hate it. They absolutely hate it. They can't stand it. And 25% of our patients, they don't love it. They don't hate it. They think, this is important, and they'll be using it. So it is tough. It's like riding a bike. And then there are some patients who have severe sleep apnea, but they don't have no symptoms. And it's hard to convince those patients to use positive pressure therapy. The way I tell them, I say, hey, listen, you have a blood pressure of 200 and you feel great. I still want to treat you. And this is not different than just taking medications for your high blood pressure. Usually with moderate or severe sleep apnea, CPAP remains the main therapy. But there, for mild sleep apnea, we have more options. We can do weight loss. I mean, we do weight loss on everybody. Right. But we can try positional therapy. There are oral appliances. There are some things that there was something actually called Prevent. Now, unfortunately, it got discontinued, but it was a really great thing. So there were like these two strips that you put on your nose, and it had a one-way valve. So you would breathe in, but when you breathe out, it would just create a little bit of a pressure in your upper airways. There's a new device called Excite OSA, where there's a device, if you put it on your tongue, you kind of train your tongue and your tongue muscles to become more rigid, so it doesn't collapse as well. So for mild sleep apnea, we have treatments, we have alternatives. If you have moderate or severe sleep apnea, usually the main therapy becomes positive pressure therapy. There are a couple of other things, like there's an Inspire, which is basically a pacemaker-like device, which has two wires that goes in your neck muscles, and when you activate them at night, it just kind of lifts up your jaw and makes these muscles rigid. So, those are reserved for people who don't really tolerate, positive pressure therapy. But,
interesting.
But most of our patients, we recommend CPAP.
Okay, so those who are hesitant, if you have mild disease, chances are you may not need it, or there's a possibility you may not need CPAP. So it's certainly recommended to get the sleep study. There are a couple of things you said, Ali, that caught my interest. One was if you have no symptoms and you have sleep apnea, which is interesting to me because I wonder how that happens. And then the other is if someone just snores and has a very loud, just snoring very loud, should they automatically get a sleep study. So those two things, could you answer for us?
Yeah, so I mean, if you're snoring, I mean, there should be there should be suspicion for sleep apnea. Now, so it's interesting because when we do a sleep study, you are allowed to stop breathing a little bit throughout the night. So there's something called AHI, and you might, if somebody goes to it, like pretty much all our patients know what their AHI is. AHI measures the severity of sleep apnea. Anything less than 5 is mild. Now, so if I do a study on you and I say, Ravi, your AHI is 4, that falls. I'm saying AHI of less than 5 is normal in adults. Okay, and I say your AHI is 4, that's considered normal. Okay, that's considered normal. So you're allowed to stop breathing a little bit. In children, it's not. You're not allowed to. Children, should not even should not stop breathing at all. And we actually are seeing more and more patients with sleep apnea among children because the incidence of obesity is increasing in children, and a lot of children, the attention deficit disorders that they have, it can be an underlying sleep apnea, or bedwetting can be a underlying sleep apnea that's not treated. Now, there is this thing called mild sleep apnea. That's a little bit gray area. It's like from 5 to 15. If you start breathing 5 to 15, what do you do? So that's a kind of a gray area. Usually, if you have no symptoms, we don't treat you. But if you have symptoms, obviously, we treat you. If you have like other cardiac conditions, the evidence is not as clear. Okay, but the guideline says if you have moderate sleep apnea, moderate is defined as AHI of 15 up to 30, or severe, and severe is defined as AHI more than 30, there is indication for treatment. So even if you say, hey, listen, I don't have any fatigue, I feel great in the morning, but if you have an AHI of 25, there is indication for treatment. Now, just like everything else, some people have no symptoms, some people, they have severe degree of coronary artery disease and blockages in their arteries, and they have no symptoms. So kind of hard to tell, predict who is going to have symptoms. But there's lots of people who are feeling so tired with even mild degree of sleep apnea. I saw this patient today, and today I was actually like half a day I was seeing patients for sleep clinic, and he had a lot of symptoms of fatigue and not feeling well rested in the morning, and AHI was only 9. And, I see people with AHI of like 80 and they don't have any symptoms. I mean, that's clearly the unknowns of medicine. Why somebody gets COVID and doesn't even feel it, and why a young person gets COVID and ends up in the ICU. So it's kind of the same concept. Yeah.
Okay. So basically, to answer those questions, you can be asymptomatic and still have sleep apnea, and you should treat it regardless. And if you
have moderate or severe sleep apnea, you should treat it regardless. Mild, it's a little bit controversial. Yeah.
Okay. And then if you are snoring, you should get a sleep study. If you have severe snoring, you should get a sleep study.
Yeah, I think snoring should be looked at because, first, snoring usually bothers significant others, and,
right.
But I mean, there are plenty of patients who just snore and they don't really have any sleep apnea. But there are treatments for their snoring as well. There's oral appliances that can use. The ENT surgeons, sometimes they do the uvuloplasty. They just basically cut your uvula, and uvula is the one that kind of when it causes snoring, the vibration. So I mean, it's a little bit painful, but it's great for snoring. Takes care of the snoring. So. We talk to if you have snoring and you have no sleep apnea and it doesn't bother you, it doesn't bother your significant other, we don't do anything. But most of the times it bothers the significant other.
Is this something that
bothered, your guy's trip, right?
Yeah, exactly. I can't imagine how their significant others would sleep next to them, but they probably say the same thing about me. So it goes all ways. Is this like something that you should do just for general health and well-being? Get a sleep study? I mean, as you get to a certain age, does it make sense given that they're so easy and they're at home?
The indications are not. Basically, the American Task Force does not recommend doing a sleep study on random people, but there are things that we look at. If you have high blood pressure, you're tired, your body mass index, but just random people doing a sleep study on everybody, like checking your cholesterol, we don't advocate that. But if there is indication for it, we advocate looking into it.
Okay, excellent. And just to end off, I know you mentioned some of the cardiovascular consequences of sleep apnea, but just, given you're a cardiologist, I know you have an interest in these. You mentioned hypertension, atrial fibrillation, coronary artery disease. What other things could you experience? So
you can actually exacerbate arrhythmia such as atrial fibrillation. So basically what's happening in these episodes, so if you have severe sleep apnea, so you get a sleep, you sleep. Okay. So what happens is that you go through these cycles of choking episodes. So you choke, then your oxygen level goes down. So these are actually significant stresses to your body. So your body continuously secretes these epinephrine and norepinephrine, which are these fight or flight hormones. Now, these are good hormones when, your body secretes them in a, fight or flight, response. If I'm like suddenly attacking you with a gun, your body's going to secrete these things because it wants to prepare you to fight me. But when you're trying to relax and your body continuously secretes these hormones at night, well, that's actually, that's bad for your health. That has that does not have a good effect on your cardiac structure. So these type of hormones, when they continuously get secreted, they can increase your blood pressures, they can increase your incidence of heart failure exacerbation, they can increase incidence of arrhythmias. But actually, a really interesting study was done. There's a cardiologist from Mayo Clinic, and he's done a lot of sleep studies. A lot of research on sleep. So he actually measures your sympathetic nerve activity continuously throughout a 24-hour period. So these are, so he basically puts a probe on your one of your, I think, radial nerves, and just measures the electrical activity. And basically, like at your baseline, you should have, like a baseline normal should be just kind of flat. And the people who had severe sleep apnea, even during the day, their nerve activity was through the roof. And then when they get started on CPAP, it just calms down and it just basically goes back to normal. So these fight or flight response hormones, epinephrine, norepinephrine, and a lot of, and a lot of other types of hormones, they can actually, increase your blood sugar, increase your cortisol level, and in the long run, they can have cardiac, they can affect your cardiac condition.
That's very interesting, because, this is not only something that we experience during this condition, so obstructive sleep apnea, but also just in general life. Many people have constant baseline level of stress. They're constantly revved up. And it just goes to show how important, just mindfulness, relaxation, being centered, really dealing with those stressors, how important that is, not just for your mental health, but also your physical well-being.
No, absolutely. Absolutely. We, again, this happens to all of us. Just the value of a good night's sleep cannot be emphasized.
Right. Well, thank you, Ali. This was very helpful. And you look like you had a good night's sleep last night. I can tell just by looking at you. You look very rested and relaxed. Makes me feel good. But thank you for sharing this with us.
It was a pleasure being here. Yeah, thank you for having me.
Absolutely. I hope you enjoyed this podcast. And if you did, please make sure to hit the subscribe and the like button and leave a comment about what you'd like to see on our future episodes. Just a reminder that this podcast is for educational purposes only. It does not substitute for professional care, nor does it constitute medical or other professional advice or services. If you're looking for medical care, please seek a qualified doctor or medical professional. For more information, or if you'd like to check out our programs, please visit our website, peakwellnesshealth.com. That's peakwellnesshealth.com.